Hello, everybody. Welcome to another episode of Unlocked, where we talk about unlocking the potential of you, the people you work with, and the people you do life with. At the time of this recording, I'm offering all of you, yes, my lovely listeners, a free 15-minute communication coaching call. You come with some kind of communication problem, and I give you a solution. My calendar link is in the show notes, so check that out. Dr. MaryAnn Wilbur is on the call today, and it's a very important call for all of us, because we're going to talk about the healthcare system. And this is the American healthcare system that we're going to be talking about and focusing on today, and just how broken it is. And this isn't a political discussion necessarily. This is really about the rate of burnout of physicians in the industry and the burden that it has on our entire healthcare system as a whole, and what it's doing to us. And the reason why I wanted to feature her on the show, I was like, I don't know, man, this is a very important topic, but I don't know if it's right, because I'm talking more about unlocking leaders and how do we understand what that's about. But we really started getting into the idea of workplace dynamics. And I want you to think about, in the heart of this issue is this idea of resources and resource management and value and bureaucracy, and all the things that are burdening our healthcare system can also burden your corporations and also burden you as a leader and as an individual. Dr. Wilbur is a non-practicing Gyn Oncology surgeon. She left her direct patient care almost 2 years ago due to concerns about the broken healthcare system. She's going to tell you that story in here. She recently interviewed hundreds of physicians in the same situation, and then she wrote a book. The information that we talk about in this interview, revealing what these individuals were saying, is eye-opening, and it's painful. The book will be out if it's not out already. It's called The Doctor Is No Longer In, and she serves on several boards. She runs her own business and a nonprofit. But she gets into this idea of, have you ever wondered why it takes so long to get in to see your physician, or why your physician keeps changing, or what's wrong with the whole hospital system, and why doesn't it operate well? And there's all types of things we're going to get into this in this interview. Pay attention. She is passionate. There's some emotion in this interview, and I hope you hear it and recognize the injustice that she is fighting. And she's put herself out on a limb to do this, and I appreciate her being on the show and talking about it. So here we come. MaryAnn, thanks for being on the show. Thanks for waking up early. Let's go hang out together. You ready?
Yep, I'm ready.
Okay. This is going to blow some people's minds, as it did mine when we first initially were talking and having conversations, because I was like, I don't know. Usually we get on, we talk about HR people and HR things, and we talk about, communication things, and we talk about all these, but your topic of this physician problem that we're having right now applies to the idea of burnout that we're experiencing in culture, but specifically to the physician and how that's all impacting society. We're going to talk about how to unlock the idea of a workforce population. We're talking about the problem that we're having. We're going to go into all that. And you are at the heart of experiencing this problem in your own story. Give us that story.
Okay. So I was a practicing GYN oncologist until almost 2 years ago. And when you go to medical school and you go to residency, that the hours are going to be long, patients are going to be sick. That was always part of the deal. But we're having problems in our system now where not only are the patients sick and the hours are long, but I physically couldn't do the right things for my patients. And once that happens enough times, it becomes this overwhelming feeling of, in the beginning, it's ineffective and exhausting, and then it becomes sort of gross, and you feel complicit in this betrayal that our system is putting on the patients. So it's a deep burnout. And it's mixed up for me. It was mixed up with moral injury, as I could not provide the level of care that my patients deserved, and I felt awful about it. And at the same time, there were some needs that were happening in my personal life, and I just got to a point where I was like, this is not sustainable. And so I stepped back from direct patient care and leaned on my 2 public health degrees and an editorial fellowship and my background in clinical research to, instead of researching patients, talking to the doctors about what they're experiencing. And is my story representative? Because if it is, there's a very big problem.
Were you surprised to hear the stories that were out there? Were you hoping that your story was an outlier? I mean, what were you thinking going into this, like, inquisitive, like, why
Yeah.
would you even go there?
Yeah. Because you always wonder, right? Especially when it's yourself. And so, imposter syndrome and all these things. You're like, maybe it is me. Maybe I'm just broken. I don't know. And then, but luckily I had this training in qualitative research. So I put together this project to talk to physicians across the country. And I mean, on some level, I knew that the problems were everywhere. I mean, that was sort of the reason I didn't leave my job. I left direct patient care. I didn't just move to another institution because I knew the problems were in the other places too. So in some level I knew, but I also thought that the extreme duress that I had experienced that led me to basically like divorce the career I had spent decades building, I thought it was probably, my story is probably extreme, right? It's probably, maybe other people are feeling it, but not quite like I felt it. And that was not true, actually. I think it's not that I got pushed further than other people. I think I was very blessed to have the opportunity to step away, whereas a lot of people are trapped in their careers right now. And I heard a lot of expletives, and we saw a lot of tears, and people literally are feeling trapped. And they feel like they got into this to help people, and now they're not helping people. They're hurting people. They're hurting themselves. They're hurting their families, and they can't figure out how to get out without causing major, not trauma, major disruption to their personal lives.
Is this are we talking about hospital system stuff? Are we talking even private practice? What's
All
the
of it.
mix there?
All of it.
All of it?
Yep. So the docs we talk to, they are all demographics, all specialties, all across the country, and everything from big academic institutions to little rural private practice, family med, all of it. The symptoms are the same.
Wow.
Yeah.
Okay. And your background were you private practice or were you hospital
No, I
system
was a GYN
university?
oncologist. It's really hard to be a GYN oncologist outside of a large system because you need ORs and blood banks and ICUs and case managers and all of that. So most GYN oncologists, because it's a complicated surgical specialty, most are within a larger system,
Okay.
which can add layers to the difficulty, but still is all the same problem.
And you took all this research and
Mm-hmm.
all these ideas and you put them into the book that is out. The doctor is no longer in. Tell us about why this is a problem. So we sit there and we go, oh wow, that's really horrible. Like burnout with our physicians that's really a problem. But okay, help us feel the pain of what's really happening as a result of this.
So in the book, we talk about, the background of U.S. history and how this came to be. But if we just sort of cut to today, the situation that we're in today is that we have built a system around the dollar and not the patient. And so, we've all experienced this on the patient end, right? You don't even have to be a physician. On the patient end, you go to see your doctor if you can get in. You finally see the doctor, and then you make a plan with your doctor, and then you can't actually access the medications or the treatment plan or whatever that your doctor prescribed. And so then the doctor gets all of this frustration and is already supposed to be seeing, many, many patients, and it now has to fight with the insurance company. So there's like all this added work, all this added documentation, billing, frustrations, and just feeling devalued. And so that is sort of the slow burn of burnout, because burnout is a syndrome where you experience extreme fatigue and sort of this sense that it doesn't matter what I do. It's like a learned hopelessness. And then as you start to have these stories where not just was it frustrating to finally get access to my patient or jump through all of these hoops, but you get to a place where you literally cannot fight the system enough to provide the care that is proper. And it creates this, what a lot of people are now referring to as moral injury. This, which is a feeling that you are so compromised morally that you are part of the problem, where you have either perpetrated or participated in a transgression to something that you hold dear, a belief that you hold dear, which is for most of us physicians that we would treat our patient the way we would treat ourselves, or we would want to be treated, or the way we would want our parents treated, or that kind of level. And when you don't hold to that, it's soul sucking.
So you go into this practice with a certain goal in mind.
Mm-hmm.
You experience the realities of what our system is, the pressures, all the brokenness of certain things, and then on the other side of it, you start going, "This isn't what I signed up for."
Yep, we heard that quote every day.
Really?
Yep, that one in particular. This is not what I signed up for. This was not the deal. This is not how I imagined it. All variations on that same.
Tell us more. Like, what else did you hear in these interviews?
Oh gosh. So I mean, that the statement that we just said was probably the most mild statement. That was the everyday, like, this is not what I signed up for. This isn't why I'm here. This is not how I imagined spending my time on earth is, to feed the almighty dollar. That's not what it do. So there was this frustration. And we heard plenty of that. But then as that happens, and then you get frustrated with the system, a lot of doctors start to push back, right? Well, I mean, we have agency. We're not, generally helpless individuals. We are rule followers for the most part. Like we went through years and years of education and training. So for the most part, we don't push much, but we are capable individuals. So then what happens is the physicians start to push back against the administration and say, this is unacceptable. I can't work like this. This is not okay. Patients are going to get hurt. It's going to be bad for all of us. And once you become a problem for the administration, then either you are told to be quiet and you listen, or you don't. And then a lot of us started getting emails with feedback about whatever label you can put on us that would make us seem unattractive. And you start to either be silenced or discredited. And then as the discrediting process gets uglier and uglier, physicians, we start to internalize it. Like, oh gosh, maybe I am a troublemaker. For me, it was that, everybody's a little bit different. So for me, I was a troublemaker for sure. I wouldn't be quiet. I was like, this is not okay. This is not okay. But I always had great patient satisfaction surveys and everything. So they couldn't say I had complaints. And I always had great, teaching awards, and the residents and the medical students all liked me. So they couldn't say I was a bully or anything like that. For me, they focused on just a couple of surgical complications, and then it was so frustrating. And they sort of silenced me. And this story it's not necessarily about me, but it happens to everybody, anybody who won't just let the beast let this factory line keep going. If you speak up, you're going to be silenced or discredited to the point of being silenced. And in that process, a lot of us internalize that and start to feel really inadequate and guilty and shameful and a lot of these like really dark feelings. And then if you push hard enough, they're like, maybe you need some time off, right? So that's exiling people. It's a very powerful social behavior, and it makes people feel awful. And that's when the physicians start to either regain their humanity and say, I don't deserve to be treated like this. Nobody deserves to be treated like this. Or they don't. And that's when the real darkness starts to set in. The depression, the anxiety, addiction, divorce. We heard about suicide attempts. I mean, and doctors don't, they don't call for attention. Physicians know how to end a life. So the couple of people I talked to about their own suicide attempts, those were solid attempts that were thwarted. But it gets really, really dark, and it's done on purpose.
Let me ask you this. Some of us out there may be thinking, wow, that's really hard. Like that really sucks. We hear about that in a lot of industries. But this is it's probably such a small part. It's probably such a small sliver of your profession. Like, is it really that big of a problem? I don't know. Like,
right.
Can you give us some meat on that?
Yeah.
How big of a problem is this?
Yeah. So, when we started this project 2 years ago, we knew that, my story was maybe an outlier. We weren't sure how extreme, the story, my story might be from the norm, but we knew 1 in 5 physicians was openly saying, I am looking to leave direct patient care. 1 in 5. And we already have a physician shortage. So that number was really scary. And actually, since then, just last month, the AMA, the American Medical Association, who kind of keeps a track on how many physicians do we have in the pipeline, how many do we have active, how many do we have retiring, they kind of keep those numbers. They just came out and said, actually, now it's 2 in 5. 2 in 5 physicians are looking to get out. Those are the physicians I talked to who are, quote unquote, planning their escape. They're trying to figure out how to do it without blowing up their lives, because that's essentially what I did. I took a major financial hit and just decided, you know what, I'm just going to suck it up and be able to look myself in the mirror, maybe not pay my bills, but I got to a point where I was like, I'm not doing it anymore. I'm not taking this money.
40%?
Yeah.
Is what we're looking at? 40% of physicians are saying, I need out.
Yeah, I got to get out
of this.
This system is so broken. And they all said the same thing. I love medicine. I love my patients. I love teaching. I love science. I love the interplay of science and the art of caring for people. Like, I love all of it. Nothing changed except I can't work like this. I can't do this anymore. And this is working inside of a system where we're trying to care for the patient in front of us, but the incentives are all aligned with the almighty dollar. And so the administration just wants us to crank more revenue and save them money so that they can siphon it off the top and give it to their shareholders.
Give me a vision of the way it should be. I want a little bit of hope. Give me some hope.
Oh, there's a lot of hope here. So medicine is just as beautiful as it always was. And I actually think what's going to happen is physicians and patients are going to team up and say, you know what, this is not okay. This system is for all of us. And so we are going to push back and say, this is not okay, and create a new system. Now, when I was younger and a little more, pie-eyed, I actually thought that the answer was going to be a single payer system. But we've tried that in the US multiple times and it doesn't work. And there's multiple reasons that we should honor. One is, really, access to care is only one part of good healthcare. Being healthy means being in an environment where you can thrive. Physicians don't even have the power to do that in the day-to-day, right? So step one is actually not access to care. It's access to the things that allow a person to thrive. So we call those the social determinants of health. So even if you could pass a single payer system, it still wouldn't necessarily improve health outcomes in the US because we have major inequities anyway, baseline. The second issue is it sounds a little too socialistic and it doesn't align with American political ideals, right? So for those two major reasons, it's not necessarily the right way to go. But so the system that we're in today is such that physicians generate the revenue. We do by doing things, right? We do surgery, we do procedures, and then we bill for them. Well, we're all hospital employed these days, or at least 75% of us are. And the hospital bills. But the insurance company says, we're not paying that price. And then there is this back and forth between administrators in the hospital and administrators on the insurance side. In the end, there are 17 people between my patient and I who came up with a plan. So for me, that story was a patient was just diagnosed with cancer, usually in the lining of her uterus, because that was the most common cancer I saw. So endometrial cancer. Comes to my office and I say, all right, well, the bad news is it's cancer. They had given you the correct diagnosis. The good news is most people are cured by a hysterectomy alone. So we're going to do a hysterectomy and then we're going to do, check your lymph nodes. We're going to do some other things. And most you'll probably be cured. And that's wonderful news. And the patient's like, okay, great, let's do that. We're going to do a hysterectomy. 17 people then review that plan that she and I just came up with. Do we need those 17 people? How much does it cost to keep 17 people on the payroll? That's how much waste there is in our system. Now imagine if we took some of that money and instead put it towards the environment where people live so that people can just have what they need. So imagine if we built a system where instead of the physician being paid like a mechanic, just based on doing things, what if our healthcare system got paid to keep people well? Now you can still do that with a business model. We don't have to fight about any political changes. It's just that the business model for our insurance companies would have to change, where their job is not to push back on the care. Their job is to say, okay, all right, hospital system, your job is to keep this 1 million people well. And here's $1 billion to do it. And, I'm making up the numbers. It depends on the demographics and blah, blah, blah. But anyway, here's a chunk of people you have to keep well. Here's a chunk of money to do it. Go. And then you look at that community and say, what do I need? Right? All of a sudden it turns it because what do I need to keep these people well? Because anything that you save, so that $1 billion, if you only spend half of it, you get to keep the rest. And then the whole team gets to benefit from that shared savings. So, what could you do for communities? That's amazing. And it actually saves money. This has been shown to work, and I didn't invent it. It's called an accountable care organization. And these have been trials. But, and here's the kicker, they started with the ACA, and they are good ideas, but there was a very big error in how they implemented them on the first go round. So that when they did this, those shared savings, because it's all about those shared savings, that then you can go back into the community or give bonuses to everybody who's working so hard. So everybody wins and feels like, yeah, I feel good about this. I'm keeping people well. I'm being, told that I'm valued. Like everything about this feels right. But if the shared savings get siphoned off the top to go to shareholders, morale and the whole thing falls apart. So you can't do that. And again, the error in the original ACOs was, again, about greed. That's what it all keeps coming back to, is that healthcare is if we're going to treat it like a business, and there's no sign that America will accept anything else, then we have to change the business model so that greed doesn't have such a powerful effect on how it works.
So why would the shareholders agree to this?
Because there actually is tremendous savings. I mean, look at all that bloat. Those 17, I mean, what do business people like to do, right? They like to cut costs. This system is bloated beyond belief. So there's a lot of ways to do better. The tricky thing is I'm trying to think how to answer the question without going through like a huge history lesson that ends up like in this tangent. So the shareholders are recognizing that there are major profits that can be siphoned off, but it comes at such a cost that they have to recognize that this is not a sustainable system. And so when you've got a business model, what you realize, like, this, we've squeezed about all we can out of this system and it's toppling over, because it's now going to cost you a fortune. Trying to replace physicians is tremendously costly. So, I mean, that alone, they're starting to recognize it, but they're still kind of in disbelief because they want to think that there's still money to be siphoned off. But the reality is the business model needs to change, and you have to stop turnover. So retain your physicians, tell them they're valued, let them do their work, so that you can stop turnover. Because each time you lose a doctor, it used to cost about $1 million to replace a doctor. Now it's closer to $2 million, just because you lose the revenue while that person leaves. And then there's usually like a severance package and whatever. And then there's the recruiting process, the interview process. All during that time, your hospital is not making money because that person is not yet operating, is not yet up, needs to get licensed and yada, yada. And they got to go through, there's like all of this process. And because we're now in a physician shortage, it's harder and harder to find. Like recruiters call all day, every day. There are jobs everywhere. And the docs really, no, I can't work like this anymore. So they don't take the jobs. And so it's getting harder and harder to refill those positions. And you can't just make a doctor. I mean, it takes decades to make a doctor. And there's a huge bottleneck in the training, in the number of training spots we have. So they're getting to a point where they're going to have to realize that continuing on this path isn't going to work, and they're going to have to change. They're going to have to stop wasting money in terms of turnover. And we're just talking about physicians, not even getting into, everybody else on the team is also burnt out, all the nurses and, nurse practitioners, everybody else. And then the administrative bloat of like paying 17 people to fight between me and my patient for a surgery that she was going to get anyway. So they have to recognize that the model isn't working and that it can work, but they're going to have to change how they do it.
Why does the US struggle with this so much? Do other countries struggle with this? Have you looked into the global aspect of this problem?
That's a very common question. So the truth is this dissatisfaction is actually happening in other countries across the globe, but the US is feeling it to a much greater extent and much more acutely, like right in the now. So I just did an interview with a physician who is, like-minded, and comes from a similar background as mine, spends a lot of time in public health and that kind of thing. And he is in Australia, which is a similar system to ours, except that there's much more public. So there's one public system, and it is very well done. So much so that most individuals choose not to pay for the private insurance, which they can. They have the freedom to do it. If you want to pay premiums, you can have the extra insurance. If for whatever reason that makes you feel better, then you can have it. But you don't need it. And if you can't afford it, the public system will serve you. And the physicians are, they're fine. It doesn't matter. They don't have to think about what kind of insurance you have or don't have, because the system is set up to just let the doctors work, which means that the first time that a patient, say, gets in my case, like I would treat cervical cancer. And in Australia, the very first time they catch a very small cervical cancer, they can just, a very small surgery to just like cut out the cancer itself can stop that in its tracks. So they can just do that surgery. In the US, if that patient's uninsured, I get tons of pushback to not do that surgery. But then when the cancer spreads in 6 months and it's everywhere, then she qualifies for Medicaid and chemo that is not going to save her for life. I mean, the system it's just so abysmal that, and you imagine how costly that is. Chemo is very expensive. This tiny little procedure, it was an office procedure. It could have been done. It's wasteful. The whole thing is wasteful. And so, I was talking to him and he was sort of appalled. But one of the biggest things is, so in our country, we created we call it health insurance. In fact, it's illness insurance, right? So, maybe I'll give you a little bit of the history lesson. So World War II happened, and before then, we didn't really have employer-based health insurance. And then when World War II happened, most of the men went to war, and the women went in the factories. The factories kept trying to steal the female workers. So like if Rosie the Riveter was particularly skilled and the other factory wanted her, they would offer her more money. And the factory started doing this. And then the federal government said, you guys, like, you have to stop doing that. It's affecting how quickly you can pump out planes and whatever else we're asking you to build. So stop doing that. And so federal law said you can't entice Rosie to go to a different factory. And factory workers weren't going to stop doing it. So what they did was they said, what can we offer Rosie that is not a higher salary? And they said, you know what Rosie's worried about? Now that ether's available, antibiotics are available, now is like quality imaging. She's going to want to make sure that if her kids gets some kind of illness, she can afford to access these physicians. We should create something called like illness insurance if somebody gets sick. And that was how the whole system was made. So Blue Cross Blue Shield was in fact the first one to do it. And they put it together pretty much the way it looks today. So they put things in place, but it was really an if you get sick, right? But what are the chances a human's going to get sick? 100%.
Yeah, 100. Something like 100.
It's right around 100 because we're all going to die. Okay. Yeah. So the system is flawed, like baseline flawed. And then in the 60s, Medicare got set up and the federal government was like, so we set the insurance company to be the payer. In the beginning, they were just going to pay the bills. That's it. Third payer system, right? Hospital bills. And then the patient doesn't pay, the insurance pays. That was the plan. But then Medicare was put in place and the federal government was the third payer. And then Medicare said, well, wait, we're not just going to pay the bills. Like, we're not going to pay just what you say. We're going to negotiate the price with you. So then they started doing that. And then Blue Cross Blue Shield was like, yeah, we can do that. There's money to be saved there, right? I mean, if they're doing it, we can do it. So then it starts to become this game. And then the insurance, and it gets to a point where the insurance company isn't paying what the hospital lost to care for the patient. So there's a gap. So then what happens with that gap? That's your copay and your increased premiums and your, all of that. So we lose. So all of a sudden, so the businessmen are like, sweet. The hospital's like, hey, we got to keep the lights on. We're going to push it back on the patient, right? And so that and that kept happening, and you see it get worse and worse and worse over the next few decades, and then it gets worse because we, when we created this business, we gave healthcare, the healthcare quote unquote business, some ease in not doing regulations the same way, thinking, well, the healthcare it's a little special. So we're not going to make the same rules. We're not going to make the businessmen play by the same rules. So they didn't put in the same antitrust laws. And healthcare is ripe for short-sighted business practices. ripe, because it kind of, the federal government said, was like, all right, we're just going to leave them, like, let them self-regulate, which is just a terrible idea, because since when did businessmen just self-regulate? I mean, so then the 70s happen, and then this is the part where, I am not, business and is not necessarily my thing, but I understand that there were some pretty significant changes in the 70s and 80s to how businesses think. Like the large businesses, GE is kind of the classic example. GE, used to take great pride in being, both very profitable business, but also sort of, a protector of the employees who worked for them and for the communities that they served. And, it was definitely a different feel. And then when the idea came that you businessmen really have only one person to answer to, and that is the shareholders, that changed everything. And so healthcare business was affected the same way GE was, the same way Boeing was, so all of these large business systems that we're watching now crumble because of short-sighted business practices. Healthcare is doing the same exact thing, but even worse, because we have even fewer regulations in place to protect against it.
Wow. So, you're now a university professor and you now teach this to all the medical students, right? So it's like, my goodness, it's so much knowledge and understanding of, like, and my wife is in the healthcare field, and she talks to me about things, and I just don't know. Like, we just don't know, because it's not our thing. We don't go in there. It's like, hey, I'm sick. I go see a doctor.
Right.
And then it's such a pain in the butt, and everybody relates. It's like, I can't get my appointment with my doctor until like 3 weeks from now. And it's like all these issues that come up that we just kind of grown with together. We just grown about together, and we just kind of accept it for what it is. Oh, that's just how our system is. And oh, that's just, and I hear that as, to me, that sounds like hopelessness. To me, that sounds like apathy. A lot of it is like, well, I don't know what to do about it. It's just how the system is. And in your book, The Doctor Is No Longer In, do you address some of these ideas of, like, what can we do about this?
Yeah.
Like, what are we all going to do? And with the nonprofit about health equity consulting and the thing that you're doing there, like, what are you doing to take action right now?
Right now, it's limited by who is willing to really step up and make change, because it's not a secret to anyone, right? Everybody knows this.
Are you just saying from the physician side who's
From
willing to step
everybody's
up,
side,
or
because
everybody? Okay.
I mean, my favorite client, I don't actually have yet, would be the CEO of an insurance company. And I would love to say to that person, this system is flawed. The business model is old. We can all see that you've just about squeezed everything you can off this business, out of this business model. We need to change. And those 17 people, those are still people, and they still need a paycheck, but let's do it in a way that actually improves patient care and then there's shared savings so that everybody can win. So in the supportive role instead of an obstructive role. And let's start rethinking how we do that, and then build ACOs and make sure that we don't siphon any of the extra shared savings off, that it goes back into the community. And then we'll grow from there. The insurance companies who don't get on board, they're just dinosaurs, and they're going to die out. And it's the CEO of the insurance company who thinks about this change that is inevitable is the client that I would absolutely love to have. But right now, that person is not coming to me. Who's coming to me are CEOs of hospital systems that are like, we're hemorrhaging doctors. What can we do? And then I tell them everything that I heard from all of the interviews, and talk about culture changes and making sure that people feel valued and making sure that they have what they need to care for their patients. I tell them, like, do not do anything trite. Physicians are smart, and they can feel the any kind of move that isn't genuine. And so we do that. I work for some public health departments with resource allocation, because a lot of states are starting to realize, like, Some places, we're all going to feel it for sure. If you're not feeling it yet, you're going to. But like all suffering, the distribution is inequitable. There are communities that are going to feel it worse. And so there are, politicians and public health departments and basically public servants who are saying, we're bracing ourselves because we know our community is particularly vulnerable. Can you help us plan ahead? So I'm doing some of that to sort of buffer more vulnerable communities. And I have a couple of potential clients actually on Capitol Hill because people are starting to think bigger. And what they're telling me is I want to be part of the change. I want to work on this antitrust regulation kind of stuff. I want to, but the people that I am beholden to, the people who vote for me and keep me in my office, are totally aware of, and they're not holding my feet to the fire. How do we educate my constituency so that they understand the risks, so that they're pushing me to do the right thing on their behalf, on behalf of our entire community? And so that is one of the biggest projects now. Is I'm actually the executive producer for a documentary that will be out next year. And the target audience is everyone, is all of us, because patients, there are a lot more patients than physicians. And so we need the patients to understand what's happening. And we need to, because all of us are human too. So physicians, I'm more worried these days as a mother and a daughter and patient myself than I am as a physician. So we all, because all of us are human, we're all patients. We all need to band together and say, this system is no longer serving us. And it's time that we begin the shift and hopefully not make it too catastrophic. So let's do it now before it really crumbles and becomes sort of like a revolution, which can be pretty messy.
Who's your book for and where do they get it?
Originally, the book was for physicians in training, physician leaders, and hospital executives, and anybody who was in a position to make change. But interestingly, as I've done interviews and meet with people, just talk about it, everybody's interested, like everybody. So then we open the target audience so that anybody can read it. We took out any medical jargon and really broke it down so that you don't need any particular degree to follow the storyline. So now it's a generalized audience.
Fantastic. That's awesome. And where is it available?
Right now you can pick up your copy at www.thedoctorisnolongerin.com. By the time this interview actually reaches the internet, it is probably already on shelves at Barnes & Noble and Amazon. And I really hope that you'll check it out.
That's amazing. If people just want to talk to you because they're like, wow, I want to step up. I want to be part of this movement. What do they do?
Yeah. So I'm now the director and CEO of Health Equity Consulting, which is a business, but we have a separate side, which is a nonprofit. So the Health Equity Foundation allows us to accept donations, and then we can choose our projects based on merit and not who can afford a consultant. So it's a two-pronged approach. So if you need a consultant, we are available. I've had the opportunity to have wonderful colleagues and friends around the country, people I've met along the way who are part of a large network that we all work together. And so you can go to healthequityconsulting.org. And if you don't need a consultant, but you want to support these efforts, we are accepting donations also. It's a 501c3, and we would love to use those funds to support efforts to protect communities until the day when we can finally really implement what needs to be done.
Well, I am grateful that I was introduced to you.
Oh, well, thank you. Same.
this whole thing, I love these eye-opening interviews. I've had a lot of them over the course of years of doing this, and my mind just goes, what? Like,
I know.
that's the benefit of having this show, is that I meet people like you that really opened my eyes to things. And then I want to go share it with everybody and say like, did you know this is happening?
This is happening all around us.
It's crazy.
And people know it. They can feel it. They're like, something's happening.
They can.
The hospitals are closing. I can't get in to see a specialist. My primary care changes every 6 months. Like, what is going on?
It's nuts.
People want to know.
They do. And I'm happy to know that, I mean, I'm sure you're not alone. I'm sure there's other voices out there that we just don't hear yet.
Yes.
And so I'm grateful that I get to now be an amplifier for the message.
If you're a physician or a patient advocate, or you'll want to geek out about this more than just learning, you can go to www.medicineforward.org. There's it's sort of like a grassroots effort to start making change, and we're aligning with other similar nonprofit organizations to sort of keep things moving.
So cool. So cool. MaryAnn, thank you for sharing your heart with us, because there is a lot of heart in there. I can hear it, and I can, experience that from the pain and the trauma and the things that you went through in your life. And now you're trying to help it not be like that for future generations. There's an injustice in the world. You see it. You think it needs to change. And I'm grateful for people like you. So thanks for being on the show, and thanks for sharing that with us.
Thank you. Thanks for having me.
That, I hope, impacted you just as much as it impacted me. My wife is in the healthcare field, and I've been talking about this interview with her over and over and over again because of the impact that I think it's going to have on all of us and the future of where we're going. It can't stay the same. What we're doing is not working, and it's hurting us. And I hope that we get out of this mindset of us against them and me against you and this dollar for that dollar. And it's all like, can we please talk about the humanity that is being overlooked in the midst of all of this? I want you to know that this was something, this is one of those interviews that I'll remember. And if you want to get involved, please contact her. Please, I know she's welcome to your help, and she would love to talk to you more about this. If this is something you want to bring her in and talk to you at your organization, please do that. Just get the ball rolling and start to make some change. We know it's going to take a while, but if we can start now, let's do it. If you want to find out more information about me, or check out the show notes where there's going to be more information and links to the things referenced in this episode, visit skotwaldron.com. And lastly, I'm asking for a little bit of love, just a little bit. So please take a moment, follow, rate the show. The algorithms like that. It helps me get the word out. I really appreciate it. Thank you. And until next time, stay unlocked.